Welcome, everyone. We've heard some compelling CEO presentations both yesterday and this morning on how the world's leading biopharma companies plan to create sustainable long-term value for shareholders and other key stakeholders. As we were building out the agenda for this conference, we felt it was also critical to have the incredibly important conversation about the systemic inequities in today's healthcare system, its role in the vaccine hesitancy equation, and moving forward, solutions to begin improving health equity, beginning with how to instill confidence in the COVID-19 vaccine, truly one of the greatest scientific achievements in recent history. We have a terrific discussion prepared for you today, which will be moderated by CNN's chief medical correspondent, Dr. Sanjay Gupta. Now, Dr. Gupta, on a personal note, I'd like to thank you for keeping your audience informed and focused on the facts and for being a trusted voice over these past 15 grueling months. Joining Dr. Gupta are three experts in their respective focus areas. First, Dr. Yeli Aluko is the Chief Medical Officer in EY America's Business Consulting Health Sector Practice. Dr. Aluko advises health system clients on strategy, business, and clinical operations, providing C-suite executives insight on health industry megatrends and enterprise growth opportunities. He is a member of the EY COVID-19 Pandemic Response Team, where he advises EY leadership on return to workplace strategies that prioritize the health and safety of its employees. Next is Dr. Judy Chevalier. Professor Chevalier is a professor of finance and economics at the Yale School of Management. Her research is in the areas of both finance and industrial organization, and her COVID-19 work includes an early study of masking, a geospatial study of the movement of nursing home workers across facilities and the spread of the virus, and a study of retail vaccine availability, which we will hear more about today. And last but certainly not least, as you may recall, we heard yesterday afternoon from Moderna's CEO, Stefan Bancel, and we are fortunate enough today to be joined by Moderna's Chief Development Officer, Dr. Melanie Iverson. Melanie leads a team that is responsible for delivering all clinical programs within the Moderna portfolio. She has more than 20 years of experience in the pharmaceutical industry, including roles at Takeda, Pfizer, and Eli Lilly. So without further ado, Dr. Gupta, I'd like to turn it over to you to begin today's conversation.
Well, thank you very much, Michael, for having me. I'm very honored to be here. And I just have to say that we spend so much time on television trying to contextualize things into these short segments. So to be able to have a discussion like this, I think is critically important. So much of our learning, I think, comes in the nuance of things. And it's worth diving deep into that, because I think some real learning and hopefully some real progress can be made by actually leaning into those types of discussions. I have enjoyed watching the scientific story of these vaccines. It is a remarkable story, one that I think will be told for generations to come and may have forever changed the pace of medical innovation. I mean, it is really worth celebrating. But as you point out, and why I'm really glad we're having this discussion, is that unless those vaccines ultimately affect the majority of people here in the United States and around the world, they won't have the same impact that they could potentially have. And one of the hindrances there is around vaccine hesitancy and also the inequities that exist in our healthcare system. I've been a reporter for some 20 years, and vaccine hesitancy is not a new issue. In fact, as we started reporting throughout this pandemic, we'd go back and look, for example, at H1N1 in 2009 and look at some of the vaccine hesitancy concerns then. And vaccine hesitancy approached 60% at one point during that pandemic 12 years ago. There were some learnings that came out in terms of how to best address that hesitancy, but it did not solve the problem or make it go away as we're seeing now. So with that sort of in mind and the background that we all now have on the vaccines, I thought we would really just sort of really narrow down on this issue, Dr. Aluko. Maybe I'll sort of start with you. I'm wondering if you might just provide an overview to get us started on some of the systemic drivers of inequities, both inside and outside of the healthcare system. And I'll just, on a personal note, I remember when I was reporting on this, Dr. Aluko, early on, I think it was March or April of last year, when some of the data came out that first showed the disparities in terms of hospitalization rates and death rates among Black and Brown Americans in places like Chicago and New Orleans versus other demographics in those areas. And two things struck me. One is that it was this sort of unmasking, I think, of the inequities that all of us knew existed, but also then it was so hard to actually get that data. that it just sort of all of a sudden, I mean, the data was asked for, and why weren't people collecting it in the first place? And I realized in part that was one of the inequities that we're talking about. People didn't even bother to look at that data initially. But having said that, I just wonder if you could give us a bit of an overview here, sir.
Absolutely. And certainly, Dr. Gupta, it's a pleasure to be part of this distinguished panel, providing insight on this very, very important and timely topic. So when we speak of systemic drivers of inequity, we are referring essentially to established structures and processes, behaviors, and social cultural norms that overtly or indeed covertly can disadvantage or even discriminate against racial minorities and other populations that are designated as vulnerable, exposing them to unequal treatment as compared to white Americans. Now, first of all, we should understand that these systemic drivers include things like unequal access to quality education, unequal access to healthcare, limited access to safe housing and stable community conditions. And additionally, these drivers also include a predisposition to unequal treatment within things like the criminal justice system, as well as unequal access to financial capital for business development or even home ownership. So the people that are at risk for these systemic drivers of inequity are broadly called vulnerable populations. Racial minorities, as we well know, are the largest and the most visible demographic of vulnerable populations that are impacted by these systemic drivers. But we should note that there are other demographics within this portfolio of people that include such as the elderly, the disabled, the homeless, and people who identify within the LGBTQ community. Now, also these systemic drivers, when viewed specifically in the context of a person's health, are referred to the social determinants of health. And these SDOHs can actually predispose a person to more risk for the development of disease due to reduced access for things like preventive healthcare and reduced ability to develop health literacy, basic health literacy. And this is all driven by limited access to quality education and economic mobility. So these vulnerable populations are within a very complex ecosystem of social determinants of health that over time can begin to predispose people to develop chronic disease, such as diabetes, such as hypertension, or obesity, simply because of their dietary choices and their lack of awareness of the benefits of the simplicity of exercise. Now, what I've just described occurs outside the health system, but the tentacles of systemic drivers, we must realize, extend into the bricks and mortar of all stakeholders within the health industry, whether it's a healthcare provider's office, or it's a health system, or it's a farmer organization, or a pay organization, or what have you. So for example, lack of insurance results in poorly coordinated care coordination and case management. And that's occurring within a hospital system. Lack of insurance can therefore impact the cost of care delivery and the efficiency of care delivery. Also, systemic biases that can become manifest through stereotyping and indeed racism that may result in unequal treatment by way of decision-making by healthcare providers. Mm-hmm. So these systemic drivers impact health trajectories both outside the healthcare system as well as inside it, both perpetuating these inequities we see today. Now, specifically to how does this play into the issue of vaccine confidence and hesitancy adoption? You mentioned this earlier, and let me emphasize that this is not a new problem, but also we need to know that the Black community is not a monolithic community, neither is the Latinx community. There's a definite history of deserved mistrust of the health industry from Black and brown people that goes back more than a century. And it's as a result of deliberate medical experimentation on Black and brown people in the United States. And as you can see from this slide that's going to come up in a minute, there's much more to this than just the infamous Tuskegee experiment. And this goes way back to 1865. There are several Tuskegees that are not known of, going back to 1845, through 1852, where physicians performed surgical experimentation on Black and brown bodies without consent, without anesthesia, and fast forward to the beginning of the Tuskegee that ran from 1932 to 1972, and as recent as 1989, where construction workers were uncovered 10,000 bones in basements of a medical school. So this is, in the context of what we're talking about, not surprising. So we need to understand that, and we need to appreciate that this problem is real in the context of these novel vaccines that are being spawned from recent clinical research, a skepticism of the safety and an incomplete understanding of the science superimposed on this baseline mistrust of how the health industry has treated Black and brown people in the context of science in the past. All of this converges to explain vaccine hesitancy in certain segments of the African American and Latinx communities.
I really appreciate that that background, Dr. Aluko. I think a lot of people do tend to become somewhat reductionist about this issue, and just bring up Tuskegee, for example, which by the way is everyone, I'm sure, who's listening knows that history, but it is horrific. It is a horrific history to think of the idea that people would have treatments withheld for syphilis in order that their bodies could be physically sort of studied to see what this untreated disease does to them. I think of, if it was my own family, you know, I would have an incredible distrust as well. I wonder, and I'm gonna bring in Professor Chevalier as well here, but the bottom line, I think, question is this an addressable, I won't say fixable, because I don't think you fix, history is history, it's part of us, but is this an addressable issue? On one hand, you have Black and brown Americans, non-monolithic, as you point out, but 2 to 3 times more likely to be hospitalized to die of this disease. On the other hand, they have adopted and been, the confidence in the vaccines have been lower among these populations, sort of more globally speaking. Professor Chevalier, I mean, when you hear Dr. Aluko discuss structural racism in this way, leading certain populations to be more vaccine reluctant than others, you've done a lot of research on this. What are the lessons learned, and what does it mean going forward?
Thanks, and thanks for having me on this panel. So I think Dr. Aluko spoke importantly about the issue of people who mistrust the vaccine, and clearly that's a big part of vaccine hesitancy. And in my early COVID work, as Mr. Rosen mentioned, used smartphone data to show that the working conditions of nursing home staff and contractors as they moved across facilities took the virus with them. And that was an important part of why nursing home workers turned out to have the most dangerous occupation, one of the most dangerous occupations in the country last year. And you know, we saw in December and January that nursing home workers did not take up the vaccine, many of whom are low-paid women, Black and brown women predominantly, that these workers didn't take up the vaccine as quickly as the patients that they were serving. And certainly some of this is exactly what Dr. Aluko is talking about, and it's so important, which is these workers definitely feel and have seen evidence that our society has not prioritized their well-being, and that is contributing to mistrusting the virus. But as an economist, it's important for me to, I think, point out other sources of what I would call vaccine hesitancy, that hesitating to take the vaccine as opposed to mistrust. And these all also relate to these inequities that Dr. Aluko mentioned, right? So People who hesitate to get the vaccine include people who are worried that the day off from work, if they get a side effect, that's a real economic struggle. And that certainly includes some of the nursing home workers we studied. The clinic at work was set up at the day shift, but you work the night shift, and they don't think about the night shift. That's one of the challenges. People have trouble organizing their work and childcare schedules around getting the vaccine, or they have jobs that make it hard to pre-commit to an appointment. All of those inequities are also inequities we're seeing in the vaccine take-up. And one that I really want to point out here is recent surveys data suggests that a lot of people are convinced there are hidden charges and that they're going to be charged for the vaccine. And why shouldn't they? Because they've been hit with hidden charges in our healthcare system so many times in ways that for some people can be really financially devastating. And so I think that this issue of mistrust that Dr. Aluko raised is so essential. But one thing that might help with mistrust is people seeing their friends get the vaccine and do well with it. And to reach those people, we really have to think about those people who are willing to take the vaccine who haven't gotten it yet. And some surveys suggest that the folks who are willing to take the vaccine but haven't gotten it yet are actually as numerous as the people who mistrust the vaccine. So these inequities are so important, but they're important, in every piece of the vaccine delivery chain.
In medicine, they like to use the term multifactorial, right? There's many different factors at play here. But I think when it comes to the idea of these historical inequities, I mean, I think all the points you raised, Professor, are really obviously critically important and real. I mean, that's just the reality of life for a lot of people in terms of why they may or may not do something. But from a broader perspective, when you look at from a social science perspective, and again, looking at the history that Dr. Aluko sort of present, I mean, Dr. Aluko, I'll come back to you. This idea of, in some ways, acting not in your own self-interest, right? On one hand, you're told this disease, COVID, 2 to 3 times, depending on the data that you look at, more likely to affect you and in a significant way, severe illness, even death. On the other hand, not getting the vaccine. There's this huge space in between that you've just very nicely elucidated. But at the end, you have to make the decision. Are you optimistic ultimately that people who would maybe most benefit from the vaccine, just purely from a medical standpoint, will actually come around and get it?
Well, it's a seeming paradox that if a person is more vulnerable to severe disease and indeed death, and knows that, and I'm speaking about the racial demographics that are more vulnerable to adverse outcomes with COVID-19, Black and brown people, it's seemingly rational to expect that person, if told that we have a vaccination that has a very high likelihood of preventing you from getting infected, certainly from dying, and if you do get infected, your infection is likely to be very minimal. If you plot the thought process between those 2 points, it's very rational to say, get the vaccination. However, if we adopt that rational linear thinking just between those 2 dots, we're completely missing the point and minimizing the importance and the impact and effect of what I just described. And in addition to the logistical issues that Professor Chevalier just mentioned, in the work that we do, we assist clients, healthcare systems and others in optimizing vaccine administration. We had academic medical center clients who realized that their minority employees, several of them were not signing up in the first waves of administration. What we found out after doing some assessments was that many of the frontline workers were being communicated to by email, and many of them had never opened their email accounts. So developing strategies to meet these populations where they are is critical. Am I optimistic? I'm optimistic only to the extent that there is an alignment at the highest level, which would be within the C-suites of all businesses within all industries, and specifically the pharma industry. This is a problem, and it's not a problem that's confined to the minority population. This is indeed a societal problem. First comes the alignment, and second comes the willingness to develop strategies and move away from just the conversation to meaningful action by way of executing strategies that mitigate the problem. To that extent, I'm optimistic that we may be successful if that is the position that we begin to adopt.
I want to bring Professor Chevalier and Dr. Iverson in this conversation in a minute, but let me just follow up on something, Dr. Aluko. On one hand, you know, it's the problems and the inequities structurally that you described, again, have been there for a long time. For many people, maybe even some people who are listening right now, it may be the first time they saw it sort of unmasked or laid bare the way that we've seen it over these past 15, 16 months. Why did it take a pandemic and the social racial unrest, you know, last summer for society to no longer ignore these injustices? And I think also importantly, is it going to go back? I mean, is this like, we talk about Tuskegee and we always talk about in the wake of some other issue, right? But have we changed as a result of that? Will we change as a result of this, or will we revert to the historical status quo, do you think? Dr. Aluko?
Oh, I see. Sorry, I didn't know that was for me. So for someone like myself that has been a student of health disparities for 20 plus years, the decibels and the momentum around this conversation comes in troughs and peaks and ebbs and flows. The issue about health disparities is not new, as you well know. And what we're seeing with COVID-19 disparities has been illuminated to the whole world based on what I would call an extreme of paradoxes. So it almost paralyzed health systems and public health infrastructures, not just in America, but across the world. And here in the US, considered to be the most industrialized country in the world, with a seemingly very sophisticated healthcare system, we revealed to ourselves and to the world the stark reality of unequal outcomes in healthcare. We knew this, but what's different about what happened with the pandemic is that all of this is playing out in real time, 24/7, on TV, in social media, and all other media outlets, real-time spotlight on the gravity of a problem and the realization that something drastically wrong was playing out in America and for the world to see. This struck a raw nerve in our entire society. I mean, for example, Black and brown people in the same city getting admitted more frequently, getting sicker, dying 2 to 3 times as often as white people in the same hospital, displayed in real time. A resounding outcry has occurred from all segments of society and from all segments of business to right this wrong. So what we have now, we have corporate America, we have philanthropic organizations, we've got religious organizations, community organizations, we've got local, state, federal government agencies, and all segments of the health industry, all seeking answers and trying to opine regarding solutions, trying to understand how together we must do better for our society. You ask an excellent question, Dr. Gupta, is this reactive? Is this sustainable? Or if this moment, as others, in time will come to pass. And this feels different though, you know, because all the elements are apparently coalescing within the conversation. And we have a unique opportunity to move the needle from the conversation to meaningful solutioning. The conversations have gone on for too long. And if we don't capture this moment, it will be a significant embarrassment to us as a nation and to moving towards our moral obligation for societal justice and elimination of health disparities.
You are the expert in this area. I just have to say, as a witness, as we all have been this past year, it does feel exactly like what you're saying, that this does feel like a significant moment, maybe one that will lead to more long-lasting change, needed change, and a little bit of a glimpse into who we are, our humanity, and I think it's really important. Dr. Iverson, I mean, I'd like to let you react to any of this, but also, you have a significant biopharma background. This is your area of expertise. When you looked at the data coming out in March and April of last year about the disproportionate impact of this disease on Black and Brown communities, I just wonder, from a biopharma standpoint, what were some of the discussions that were going on? Because obviously the race was for the vaccine, but unless the vaccine could be, sort of applied appropriately across communities, it wouldn't have the same impact. Were those communications discussions happening early?
Oh, absolutely. That's everything we were thinking about. So I think everyone knows the development of this vaccine happened unbelievably quickly, with the phase 1 in March, the phase 2 study in May, and the phase 3 starting in July. Unprecedented timelines for the development of a vaccine. By definition, all participants in our phase 3 trial needed to be at risk of COVID-19 infection. They had to be either through occupation or through their living situation to be at risk of infection, as well as we were looking at comorbidities. And so by the very design of the trial, we wanted to absolutely get this right. We wanted a trial so that at the end of it, we'd be able to look back and say, this represented the population of America. This represented the populations at risk. So the conversations were very easy to have, which was we absolutely have to change the way vaccine research is being done very, very quickly in the middle of a pandemic, which is an incredibly bold undertaking. I can assure you there was no pushback from anybody about doing the right thing here. And we knew that we had to recruit a population representative of the US into our trial, which we successfully managed to do. I would like to sort of pull out a strand Dr. Aluko was saying, though. Tuskegee was mentioned more to our investigators and our doctors running this trial during that period of time over the summer than they'd heard in the last 10 years. It was on everybody's lips, and it was about building trust with communities. It was about providing people with the right information. It was about having a clear strategy, and it was about making very difficult decisions, which for us included actually slowing down the enrollment of our trial. When it looked as if we had too many Caucasians in our study, we actually stopped enrollment of Caucasians into our trial in the middle of a pandemic and said, no, we've got to do the right thing and enroll a population representative of the whole of the US. And if that takes a little bit longer to build that trust, if it takes a bit longer to do the right kind of outreach, that's what we're going to do. And that was fully supported by the leadership as absolutely the right thing to do. And I think it's something the industry has been talking about for a very long time, but this was the call to action, to actually do something about it. And I hope that this has actually fast-tracked this conversation and these strategies by a decade within the industry. And I really think it will.
The trial design, as you mentioned, a very important part of the discussion, and there was a slowdown of Moderna's enrollment to make sure, and I want to make sure I understand this correctly, that the trial participants reflected the population or reflected the burden of disease, because these are two different things a little bit.
Yes, no, absolutely. It reflected the population. So ultimately, this was a vaccine that was being designed to be taken by the entire population. The trial design itself reflected people who are at risk of infection. The population of the study reflected the population of the United States of America.
What is the biopharma's obligation in terms of conveying to the stakeholders, all the various stakeholders, from a communication standpoint, the confidence that people should have in this vaccine? Again, I know that if you're a biopharma company, you're making a product, but how do you sort of balance the making of the product with the communication around that product, especially when it comes to something like COVID, which has had this disparate impact on different populations?
Well, I think, at the end of the day, in the particular case of the COVID-19 vaccine, we wanted to be able for people to find themselves in our trial. That was the most important thing. We were incredibly transparent about that. We were the first company to put an unredacted protocol onto our website. We put our diversity and our enrollment information onto our website every week. We provided a great deal of information around what we would do. We tried to be really transparent in unprecedented ways. We built relationships with sort of community leaders and community engagement. And when we look at the data that we have today, we have, I was chatting to a health equity expert that we've spent a lot of time with. And I said, how do you use that information? And she said, a lot of it is one-to-one conversations. It's about building confidence within individuals, saying, but you can find yourself in this trial. Someone like you is in this study. And that's where I think a clinical trial offers enormous value to people who are then helping people feel that they are part of that research, or someone like them is part of that research. Now, in COVID-19, our vaccines then went on to have obviously enormous real-world evidence data being collected in weeks. Very unusual. Pandemic vaccines are a little bit different from everything else, obviously. But I think our next stage for us is to look at how we'll be developing all our vaccines and therapeutics. And we are making commitments up front that we will be looking at the populations most impacted by these diseases. For example, CMV is our next vaccine that's going to go into phase 3. And we will be making public statements about where the communities and the diversity that we want in our trials. We've already done that for our CMV program, and we will continue to do that so that people can know that our vaccines really represent the populations most impacted.
Professor Chevalier, it's interesting because trial design was a big topic of discussion. A lot of people who knew nothing about vaccines, let alone trial design, learned a lot this past year about how that all comes together. And it was important because that was one of those things that the thinking was would help build confidence. Look at our trial design. Look at who's being represented here. That is the population, the heterogeneous population that we're trying to serve. We knew going into the summer that people had differing opinions on this, whether or not we'd actually have an authorized vaccine by the end of the year. But at some point, it became increasingly clear that things were looking promising. The strategies at that point to communicate with the population of people who might most benefit from these vaccines still seemed somewhat reactive, to borrow one of Professor Aluko's words, by the time we came around to the end of 2020 and early 2021. Why is that, do you think? And what are the lessons going forward? Because we may have this happen again, not just another pandemic, but frankly, even booster shots potentially throughout this pandemic. What are the lessons learned so we're not feeling like we're caught so flat-footed?
Yeah, I think that's a great question. I think that, Dr. Iverson mentioned they had to slow down a little bit in order to get that representation. And of course, what you want in the next pandemic is to get that kind of representation without having to slow down, right? And that's related to this idea of, the job we did with communication. I think what we've seen over the course of the rollout of the vaccine is that we've ultimately done a pretty good job eventually of trying to communicate, getting the vaccine closer to people, more accessible to people. But some of the strategies we used for distributing the vaccine are strategies we should be doing to keep touch points with folks after this pandemic and preparing for the next one. So those mobile vans, those pop-up clinics, those vaccine clinics at churches, those vaccine clinics at the barber shops. We don't need to wait for the next pandemic if we can figure out ways to leverage those for the flu shot, to help qualified people sign up for benefits they're entitled to but don't know about, to recruit clinical trial subjects, to provide health information. If we are meeting people where they are for a variety of things, then that will help when there's something that's urgent to communicate, that we are trying to, right now we're trying to get people to take the vaccine. Maybe we should be engaging with folks in the same way when we're not trying to get them to do trying to get people to do something, but when we have other services and things to offer. So things like using those channels to help people sign up for benefits that they're entitled to, using those channels to tell people about new medications that are available, using those channels in a variety of ways so that next time those channels are there, they're open and they're developed in order to communicate.
Did you have any hesitation, Professor, about getting the vaccine?
Me? No, I think, there's a whole category of people who are probably writing little computer programs to figure out when the next appointment was. That was me. There are people who don't want it. A lot of my research is on the people in the middle who are looking for an opportunity, but no, I certainly didn't have any hesitancy.
Professor Aluko, did you have any hesitancy?
Now, that's a great question, because I didn't have hesitance, but I had a lot of curiosity regarding the new technology, and at the time, the proposed speed to development. Never ever happened in the history of vaccine development. I had to understand the science, and as a physician, it was easy for me to do so. I had to understand the demographic mix of people within the trials, and for me, again, it was easier than average to do so. But once I knew the science, once I understood the efficacy and the safety and the rigor of the clinical trial design, I was totally sold. So I needed to be educated. Yeah. I was able to educate myself. What's lacking is now having ambassadors that can bring that same level of confidence to lay people so that they can make objective decisions that are in their best interest. And if with insight that is credible and validated, if a rational thinking adult person decides that they don't want to get vaccinated, then that's their choice. So I didn't have hesitancy. I had to understand the process.
It's interesting when you go back and look at the data from 2009 in terms of what actually helped move the movable middle, as Professor Chevalier was sort of referring to. It oftentimes was not these big ad campaigns or celebrity or athletes, sort of touting the benefits of the vaccine. It was typically people's own communities and specifically their own primary care providers, typically who really filled that gap for them. As it sounds like you're alluding to, Dr. Aluko. But when you hear Dr. Iverson talk about COVE, this clinical trial design, from a historical perspective, do you think that will have an impact going forward? I mean, will it ultimately increase confidence if people see more people like them in a trial? Does that translate into increased confidence?
It may and it may not. It all depends on how Big Pharma develop strategies, not just around vaccines, clinical designs around vaccines, but in the big picture, how they develop strategies that embrace the unique nuances and risk elements within different populations. You know as well as I do, Dr. Gupta, that most of these clinical outcomes, these adverse outcomes, have nothing to do with genetics. They have a lot to do with the social determinants of health. So until Big Pharma develops strategy that they hold themselves accountable for, things may or may not change. Now, what the vaccine companies have done thus far has been nothing short of admirable by way of the science, by way of the demographic mix. But then again, in the context of what's going on in clinical trials, and you'll see from the next slide that's going to pop up here in a minute, there continues to be a stark underrepresentation of minorities up until now. You saw what I described going back more than 100 years to up to about 20 years ago. But what you see now is actual evidence that 2015 to 2019, just 2 years ago, new FDA approved drugs. There's a stark underrepresentation of minorities. This is 2 years ago. So the industry has known about this gap for decades. And despite what has happened with the vaccine rollouts, development of the vaccine, less so the rollout, but the development of the vaccine, we still have a problem. On the left side, this represents African-American representation. On the right side, Latino representation. Very small representation, Black or African-American, 7%. And if you consider that suicide is the top 3 cause of death for Asian American women under the age of 45, that demographic of Asian American women is less than 1% of clinical trials for these type of drugs. African American men, twice as likely as their Caucasian counterparts to die from prostate cancer, but they're less than 5% of clinical trial participants up until 2019. So this is a stark reality as to what's happening now.
I really hope that people can all have access to these slides because this is really interesting data to see it sort of laid out like that. It really, those numbers and those graphs really tell an important story. Ultimately, we all, part of this discussion, I guess, is to look at that history, but also to think about real world solutions going forward. And there was this fascinating conversation that was happening between the CDC and Dollar General, as Professor Chevalier knows very well. Dollar General is a general merchandise retailer. The goal was to leverage that gigantic footprint that they have, particularly in underserved communities, to increase access to the COVID-19 vaccine. At the same time, Professor, you and your colleagues at Yale were embarking on this really fascinating geospatial study to examine how expanding distribution programs like into Dollar General could increase access. And I'm just wondering if you could tell us a little bit about that study and maybe just some of the context of what got you interested.
Sure. So yeah, our research project is related to that CDC proposal that was announced back in March, but I think it has broader lessons for distribution, both in the United States and also actually outside the United States, because we've seen that every country that's turned the corner into, something more like vaccine plenty has struggled with inequities in different populations taking up the vaccine. So I'm an economist, and so I became interested in this when I heard about the proposal, and that's because I study retail. And what do retailers do? Well, retailers find locations where they can target specific demographics and generate foot traffic. And modern retailers like Dollar General have an army of data scientists helping them to do that, right? So they've thought about where can we get people to come and target specific demographics. What we liked about the CDC's Dollar General proposal was, here's a company whose entire business model is to target low-income consumers in retail deserts and get foot traffic into their stores. And they have more than 16,000 locations in the United States. So of course that makes them a great place to make the vaccine more convenient. In our research, we look at the Federal Retail Pharmacy Partner Program. Folks on this call probably know that this program is unusual in the United States in that it put the vaccine into about 30,000 retail pharmacies. And when the Biden administration says that 90% of Americans live within 5 miles of a vaccine site, they can say that because of the Federal Retail Pharmacy Partner Program. That distribution to retail pharmacies is a big part of why folks are pretty close to vaccine. But we show in our research that actually low-income Americans, which are a group that are much less likely to have taken up the vaccine right now, are actually slightly less likely to live within a mile of a federal pharmacy partner than high-income Americans. And that's really bad because low-income Americans are more likely to face transportation and other challenges in getting the vaccine. I'm going to show you a slide real quick, which is a picture from our paper. You guys seeing that?
Mm-hmm.
So folks on this call probably know about the CDC's Social Vulnerability Index. Dr. Aluko referred to it. The CDC measures each census tract in the United States and ranks how socially vulnerable it is. And This first panel here is the members of the Federal Retail Pharmacy Partner Program and their locations by SVI decile. And you can see that less than 10% of the retail pharmacies are in the highest vulnerability area. The most vulnerable areas actually have the least retail pharmacies. And that's a measure of vulnerability as a measure of poverty and as a measure of a variety of other things. Dollar General, in contrast, that's the second panel, is overrepresented in the high vulnerability areas. It's a place that's accessible and easy for a variety of people to go to who aren't close to a retail pharmacy. This wasn't part of the CDC proposal, but there's another dollar store chain, Dollar Tree, Family Dollar. They're wildly overrepresented in high social vulnerability areas. We show in our paper that if the federal government added Dollar General to the partnership, they would radically improve proximity to vaccine for low-income people, in particular relative to high-income people, especially in the South and Midwest, where vaccine take-up has been lagging. So, for example, in South Carolina, 27% of the people who live in households that earn under $35,000 live within a mile of a current federal retail pharmacy partner. But if you added South Carolina's Dollar Generals to the program, that would rise to 45%. I'm really enthusiastic about the Biden administration's partnership with Black-owned barbershops. I think that's great, but that's 1,000 locations. In our paper, actually, one of the things we show is that one of the bigger disparities in vaccine take-up is that Hispanic people are very disproportionately likely not to live near a federal retail pharmacy partner. They're farther from federal retail pharmacy partners. And maybe not coincidentally, Hispanic people are the most likely to report that they are willing to get a shot, but haven't gotten one yet. So, I think I still would like to see the US engage the data analytics that retailers have been working on for years and try to piggyback on that in order to get the vaccine closer to people. These are places that people go to multiple times in a week, typically. But I also think this is a message for other countries, because almost every country has some retailers that are focused on exactly the demographic groups where they may have challenges in getting the vaccine. And so using this strategy of using retailers, which we did partially with the Federal Retail Pharmacy Partner Program, I think is important. And it's important for the vaccine, but I think it's also important to think about these kind of strategies for, again, benefit sign up, the flu shot, and other ways in which we want to be able to reach folks.
That is really, it's fascinating data again. And, there's a couple things that jump out at me, and I want to get Dr. Iverson and Dr. Aluko to weigh in on this as well. From an economist standpoint, Professor Svali, this idea that addressing access the way that you're talking about here, really understanding where people are and making sure the access is addressed, sounds like an obvious point. But I do wonder, are there potential downsides as well? And here's what I mean, is that if the fundamental problem, aside from logistics, and I'd like to get it, I just can't get it, but I have a lack of confidence in this vaccine, does this help that just by creating more access? You see more people in your community maybe getting the vaccine, or could it potentially harm it? Because this is not you think of a vaccine being administered in a medical setting of some sort, and the prestige or the sort of the authenticity that comes with that. I don't know. I'm just riffing with you here, and I'll let you come back to that. But let me ask Dr. Iverson, when you hear about an academic study like this and these discussions happening with the CDC and these types of merchandise retailers, what goes through your mind?
So I think anything that increases access is a very positive thing. But I think to your point around the medical setting, that's also incredibly important. What we heard from all the different communities is, don't treat us differently, give us the information so that we can make an informed decision. I think that's exactly what Dr. Aluko said. He needed to find the information to make an informed decision for himself, and that's what we hope everybody is doing. Certainly from us, when from a clinical trial perspective, we actually took our trial out into the communities through community engagement advocates, through building satellite sites. We actually did something similar on geospatial footprinting of each site and helped our sites guide them into different areas around their communities. And then provided everybody with information. That is so critical, to give everybody the information to make an informed decision. So yes, having more access is absolutely step one, but then provide change agents, community engagement, helping people understand what that access gives them, I think is the next critical step.
Yeah, I agreed. And Dr. Luca, what do you think? I mean, again, this balance between access and confidence, they're not the same thing. And as Professor Chevalier and Dr. Iverson point out, I mean, they're both critically important, but do you rob Peter to pay Paul a little bit sometimes with these strategies?
Well, sometimes you inevitably rob Peter to pay Paul, because sometimes you have to make investments into society. But going back to what Dr. Iverson has just described, let me just say that that's an excellent example of a masterclass business school case study in identifying a problem, developing alignment about the need to fix the problem, developing a strategy to do so, and then identifying supply chain components that make it happen. Now, we sent the first man to the moon more than 50 plus years ago, and billionaires are now sending themselves to the moon. And we still can't do in a integrated format what has just been described about addressing the partnerships in an innovative manner, stepping outside the box to distribute, get confidence within vulnerable populations. Let me be blunt here. The reason why this continues to exist is because America has failed its Black and brown people when it comes to issues that may be relegated to problems within the Black and brown community. So until we acknowledge that, we are still having conversations. I said earlier that I think that the moment is now, because the conversations are getting broader and more visible with all stakeholders talking about it. But if we can do what has been just described in a narrow slice of operations, why can't we expand that and scale it? Your colleague Fareed Zakaria said that for decades, nothing happens. And then in a matter of weeks, decades may happen. He was speaking about telemedicine adoption in the pandemic. It took the pandemic to accelerate the adoption of telemedicine, which for 20 years, we had the technology, we had the people, we had the governmental issues that were delaying it. But within the flip of a switch, literally 6 to 8 weeks, the entire industry had stood up telemedicine. So things can be done if leadership wants them to be done. And that is why I say that I have cautious optimism that leadership may now be at a place where they understand that this issue is not an issue just for Black and brown people. It's a societal issue at large.
You know, in 15 months, I mean, that may be one of the more optimistic ways of looking at this that I've heard. And I really appreciate that. I mean, I can tell you, just again, my own anecdotal personal experience, I say everything with great humility, you know, is that you're absolutely right on the telemedicine. I work at Emory, as you know, and it was, as was shared with me, between the beginning of January, beginning of 2020, January 2020, through the end of February, there were 80 total telehealth visits in our hospital system, 80. And by the end of May, it was 80,000. Which was incredible. It had to happen because of the situation that we're in. But all of a sudden, this amazing technology that had existed and was available, it just hadn't been adopted for whatever reason. All of a sudden, as Fareed mentioned, decades happened within a few weeks. I think the question that you're raising, and you know, I'll ask everyone sort of for their closing thoughts on this, is that is it going to stay? With telehealth, just to be very pragmatic, part of that is based on reimbursements. If those visits continue to get reimbursed at the same rate, my guess is they will stay. If they start getting minimized from a policy perspective, it will start to diminish again. That same metaphor, how do you think about that with inequities in healthcare? Yes, this has been laid bare. Yes, we've seen our moral obligations. Professor Chevalier, just in your closing comments, do you think that we are on a new trajectory now, and it's a good one?
Well, I'm optimistic like the rest of the panelists, but I think that as Dr. Aluko has pointed out, that urgency that we see in trying to get people the vaccine, we need that urgency in all aspects of
Dr. Chevalier, I can't hear you. I'm not sure if others can.
Oh.
Very faint, yes.
Sorry. I got lost. Can you hear me now?
It's very faint. Tell you what, let's let you
Yes.
fiddle with that for a second, and maybe Dr. Iverson, maybe I could just get your closing thoughts on this. And I'm not trying to end this on a pessimistic note by any means. All these things that we talk about, sustainability is one of these words that sometimes people bring up as an excuse not to do things. Is it sustainable? Well, it's not, therefore we won't do anything. I think that's the wrong way of looking at it personally. But, Professor Aluko, Dr. Aluko gave the example of telehealth and how it has changed. We'll see if those changes last. What about with these inequities in healthcare and vaccine hesitancy as a sort of metaphor for all of it?
Well, I will just say telehealth is an interesting one because we've all struggled as an industry to get it adopted into clinical trials until this happened. And then we all started using it in clinical trials. It's completely changed the way we are approaching clinical research and the development of vaccines and therapeutics. And I am incredibly optimistic that it's going to change everything. That this is an expectation of the industry in the way vaccines and therapeutics are developed so that everybody can find themselves in the trial in the future. That's how it should be done. And it's down to everybody to hold us accountable. We as an industry are very good at talking about these things and setting up initiatives and work streams and people with fancy titles. But we actually did something this time. This time we did something, and the industry must now be held accountable, all of us together, to keep the momentum going and to partner with academics and experts to make sure that we are taking the best research, the best insights, learning, educating ourselves, developing the expertise, and continuing to do this the right way.
Well, thank you, Dr. Iverson, and thank you as well. As a lot of people may be listening, I got my vaccine. I just want to say I had no hesitancy, and my 3 girls, I have 3 children, all between the ages of 12 and 15, are now vaccinated as well. Not the Moderna one, but nevertheless a very similar vaccine because it was available to them now. It's incredible. Like I started off this conversation, it is an incredible story. And now we're hearing, as of yesterday, I think, that possibly as young as 5-year-olds may have an authorized vaccine by this early fall. So that's a very pragmatic development in so many people's lives as they think about going back to school. I don't know if you're, Professor Chevalier, if your microphone's working now, but I certainly want to give you the opportunity to, if there's a call to action from everything that you've learned that you'd like to leave us with. It's, you know what, we live in our Zoom world, so it's okay that you're not muted, so it's something else going on with your microphone.
It's worn out.
It's worn out.
Yes. Probably is.
Well, we will. I think we got a good sense, and I really do appreciate the data around Dollar General, and I appreciate the enthusiasm, Professor Aluko, that you have around that. When I first read it, it took me some time to absorb this in terms of what it would mean going forward. But Dr. Aluko, do you have a call to action? I mean, what would you like to see going forward from biopharma, from leaders in policy, to make sure that we can at least mitigate some of the problems we've seen around vaccine hesitancy this time around?
I do. Couple, 2 or 3 things I will share. First of all, there needs to be an understanding that the problem around vaccine hesitancy affects all society, not just those that are vaccine hesitant. Failing to address this impacts successful achievement of community immunity. So therefore, we have a sustained problem with pandemic containment. Now, the C-suite needs to acknowledge this to be a problem in a meaningful way, not in tacit endorsement, and understand the historical context where this is rooted in, and don't minimize importance. That's number one. Number two, develop alignment around that and develop strategy, as has been described earlier a few minutes ago, that mitigate the risk in these populations through targeted communication efforts and logistical standing up of supply chains. These initiatives must be customized to reach these very demographics that are not monolithic. Therefore, different strategies may need to be executed upon, but you have to first of all understand that this is not monolithic. Hold yourselves accountable for the execution of this. And finally, in the broader context of clinical trial enrollment, there needs to be the development of alignment around why it's important. And we know why it's important. What we need to ask ourselves is, since we know why it's important, why don't we hold ourselves accountable to it?
Yeah, no question. This phrase that we're all in this together has come up so many times, over this past year and a half, but I think never more so than with a contagious disease like this. It's interesting. We only talk domestically, but these same conversations are obviously conversations that apply to the whole world, such as the nature of a pandemic. I have my father lives in the United States. We have a uncle who lives in India, who lived in India around the same age, who passed away during this most recent surge of COVID cases in India. And it was heartbreaking. He was a favorite uncle of ours. He was the natural storyteller, sort of the most permissive of all of our uncles for the cousins. And I was sitting with my dad one evening, and it just got around to this conversation where he basically said, had he still lived in India and would not have been able to get vaccinated, my uncle had not been vaccinated yet, he may have suffered the same fate. Whereas if my uncle lived in the United States, he may have been able to get vaccinated and been protected. We don't know for sure, obviously, but it was a very tangible moment for us as a family to sort of look at the importance of vaccines, as you point out. Thank you, everybody. I really enjoyed the conversation. Like I said, everything I think so much of our learning lies in the gray areas in between, in the nuance. So thank you for that. And I felt like it was a very tangible conversation as well, Michael. Some real solutions being presented, and hopefully those solutions being useful for this pandemic, but also as part of lessons learned going forward, either for this pandemic or future ones. So Michael, thank you for letting me be a part of it.
Thank you, Dr. Gupta, and thank you to Dr. Aluko, Dr. Chevalier, and Dr. Iverson for your contributions to today's discussion. While I hope this is not the last conversation we have on this important topic, I certainly hope this conversation helps lead to action. So right now, please join our next and final session featuring SASB board member Suzanne Stormer, Biopharma Sustainability Roundtable's Tom Schweiler, and ESG analyst Laura Motti. Thanks, everyone, and stay safe out there.
Thank you.